All right, good morning, everyone. Thank you for accommodating our change in schedule. Appreciate the flexibility. The first item of business on our Health and Hospital Committee meeting today is to simply call the meeting to order, which requires a roll call to establish the presence of the quorum. So I will look to the clerk and ask her to conduct the roll call so we may call the meeting to order.
Vice Chairperson Lee.
Good morning, President.
Chairperson Semidian.
Here, thank you very much. And that takes us to item number 2, which is public comment. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of the committee. And we will see what the clerk has in the way of folks who want to comment. Okay. We have one person on item number 2, is that correct? Yes. All right. And with that one person in the chambers, let me turn to the clerk and ask, do we have anyone online who would like to speak under item number 2?
We do not.
All right. Then we will say we have just that one speaker, and we will go to Paul Soto. And Mr. Soto, under the rules of the board, is contained in our published agenda. You have up to 3 minutes. Welcome and good morning, sir.
Thank you. Good morning. Paul Soto from the Horseshoe. I'm going to be reading from an article that came out February 6th of 2023 in the East Bay Times, not the San Jose Mercury. And I quote, "State regulators have discovered a slew of violations, including incidents involving death and serious injury of suicidal patients at Santa Clara County's main hospital in San Jose, jeopardizing critically needed Medicare reimbursements." Documents obtained by the Bay Area News Group revealed that state-led investigation last fall of Santa Clara Valley Medical Center, California's second largest public health system, found care deficiencies that could leave the facility in financially perilous position should they not be corrected to the satisfaction of federal regulators. In both instances, investigators found the hospital's own policies on managing suicidal patients were not followed. Let me repeat that. Managing suicidal patients were not followed, their own policies. In the case of the patient's death, the hospital was not supposed to have objects inside the person's room that could be picked up and thrown. In the injury case, the patient was supposed to be observed but was left unattended. Then they ran out of the emergency department, left the hospital, ran to an adjacent building, jumped off the high floor roof, and he returned as a trauma patient with critical injuries. Again, there's going to be just flat faces like this means nothing. This is happening in our community. What are you going to do about it? This is the proper body to listen to this. I want to know specifically, what are you going to do? This can no longer be tolerated for a variety of reasons. I only got 3 minutes. Give me 10. Give me 10 minutes, and I will lay out my case.
Excuse the interruption, properly. Sir. Let's stop the clock. Mr. Soto, if I could ask you to just lower your volume a little bit, please, sir.
Sure.
Thank you.
Sure. The instances where there's multiple pieces. The first piece is that there is the issue with the care within the hospital. The second piece is that the public has to pay out of my money, tax money, has to pay out when these people file lawsuits against the county. Those lawsuits never see a trial, which means that the county never accepts accountability for it. Never, never. In the instance of Juan Nunez, no fault, no fault. So I, as a citizen, I'm paying and doling out all these millions and millions of dollars, and there is no trial. So I never get to find out the truth. Public money is being used to cover up what the county is doing. That is disgusting. That is disgusting, and it should not be tolerated in any kind of democratic society, ever, ever. There should never be a tolerance for that. I would like these issues addressed about what's happening over there in the psychiatric care of this hospital. Thank you.
Thank you very much. And for those of you with an interest in that particular matter, I should indicate that we will hear very briefly about the CMS matter as part of item 10C when we hear from the director of the Health and Hospital System, Mr. Lorenz. But the item will be formally agendized in consultation with staff and county council for our March HHC meeting so that we can have an agendized and very thorough discussion at that time. All right, thank you very much. I believe that concludes public comment, and that takes us to item number 3, which is the consent calendar and any changes to the committee agenda. And Supervisor Lee, before we make some judgments about that, I believe we have one card, again from Mr. Soto, on the consent calendar. Mr. Soto, would you like to come up? And on this item, the clerk has set your clock at 2 minutes, sir.
Thank you. Paul Soto from the Horseshoe. The minute orders do not reflect any public comments. I go through and I review all the minute orders that are produced from these meetings. What it's going to state is, member of the public spoke. That's it. I'm a researcher. I'm not talking to you. I'm talking to individuals 100 years from now. When they look back at this point in time, they're not going to see any objections inside these minute orders. In city minute orders, I know because I've researched them. This is a part of my research. When I'm researching history, I go back to city documents. When I look in those documents, their minute orders, it reflects what happened. It's not verbatim, but it basically captures the gist and the meaning. It's a very unique skill to have when you're writing minute orders. What this county is getting away with is not reflecting anything, which means it's covering up the crimes. And that means it knows that it is covering up crimes from the future, because when the future looks back on this time, it's not going to see anything reflected there. Oh, well, there was no public objections. Everything was fine in this county. No, it wasn't. No, it wasn't. I mean, it's evil in the sense that it is aware. The county is aware that it is communicating with the future so that when the future looks back on the present, so what that means is the present is the future. The present is the future. And we are literally intentionally covering up these crimes against humanity in the present because we know that the future will look upon it. I'm not going to tolerate that anymore. So I want a meeting with the county council and determine what kind of verbiage is going to be used in these minute orders, because public comment should be reflected in them. Thank you.
Let me confirm with the clerk. We have no other speakers on item number 3. The clerk indicates that that is the case. Supervisor Lee, if you're amenable, a motion to approve the consent calendar as contained in our published agenda would be appropriate at this time. That would be items 11 through 17 on consent.
Yes, so moved. And I'd also like to add item number 9 onto consent, if you so approve as well.
I'd like to keep item number 9 on our agenda for a brief
Okay, sure.
conversation.
I'd like
if
to
you're
talk about
okay with
that.
Thank you very
Sure,
much.
no worries. And then the other item I want to ask is that this past Monday, on February 6th, the Behavioral Health Department has provided an off-agenda report relating to medical detox services, access and data. And I would like to also request an item for medical detox be agendized for a future Health and Hospital Committee meeting, if
All
that would
right.
be possible.
I'll ask my staff, and I see Mr. Savage from my office is here. We'll work, won't commit to a particular date today. We want to assess what the workload will be at the coming meetings, but thank you very much.
That's all I have. Thank you.
Thank you. All right, we have a motion to approve the consent calendar as contained in our published agenda and a request to agendize the off-agenda report that we received that Supervisor Lee referenced to a date yet to be determined, and I will happily second that. And we'll just indicate before we call for a roll that we do have a hard stop today because, again, we're managing some scheduling issues, and we are following this meeting with a meeting of our Federal Affairs Advocacy Task Force. So we have a hard stop today at 12 for this meeting, and then we will start the Federal Affairs Advocacy Task Force meeting at 12:15. Madam Clerk, did I get that right?
I believe so.
Thank you very much. All right. Call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simitian?
Aye. All right, thank you very much. Consent calendar passes unanimously. That takes us to item number 4, recommendations relating to medical staff and allied health professionals. I'm going to ask everybody to just pause for a moment because we have some Levine Act issues here. Madam Clerk, do we not have the Levine Act designation on any of these items today? And I apologize if I'm putting you on the spot suddenly. County Council's got their light on, maybe.
I
can we-
believe Council's office confirmed that this agenda did not contain Levine Act items.
That's correct.
Let me ask the County Council, is it your view that item number 4 is not a Levine Act item? Because I raised this issue previously.
That's correct. Our analysis is because the privilege sets are not person-specific, unlike the specific credentialing decisions that have now been moved to the board agenda, that the Levine Act is not implicated by what is now under item 4.
All right. In the category of threading needles carefully, I think you just did so, so I'm going to ask you to do it one more time. Say it loud, say it proud. The privileges,
The privilege sets, I think, is the term that has been used.
okay, privilege sets, thank you, are not a Levine Act item. And what is or might be a Levine Act item, which will be going to the full board?
When you are making specific approving credentialing decisions about specific practitioners, which used to be 4A of this type of item in past agendas, but now that item has been moved to the full board agenda.
All right. Thank you, Madam Clerk. Thank you, County Council. I don't believe we have any cards on this item. I'm looking to the clerk to confirm that. Supervisor Lee, if you want to lean in and move approval.
Yes, so moved.
Motion by Lee, second by Simidian. Doctor, welcome. Anything you want to share?
Yes, I'm Dr. Harry Morrison. I'm the enterprise president of the medical staff. Thank you, Supervisor Simidian, Supervisor Lee. And I'm here to present the Enterprise Medical Executive Committee items to the committee and report back to the committee on the request from Supervisor Lee at the January meeting. In January, I presented the privilege sets for approval for the nurse practitioners and physician assistants in the emergency department. Supervisor Lee inquired as to why the scope of the nurse practitioner privileges did not include certain privileges such as endotracheal tube intubation, chest tube placement, and paracentesis, and asked for a report back. The scope of the ED, or emergency department privilege set, did not include those privileges because the nurse practitioners are not currently practicing those procedures, and there is no request by the individuals using the privileges or the department to add them. If there is a request to add these procedures in the future, we can work with the department to evaluate competency and safety before bringing back any request to add these privileges to the privilege set. In general, the process is that the scope of privileges for allied health professionals, both nurse practitioners and physician assistants, are initially reviewed through the Enterprise Interdisciplinary Practice Committee. About half of its membership includes nurse practitioners and physician assistants who represent a broad spectrum of practice areas. Any nurse practitioner or physician assistant or medical staff member who has concerns about the scope of the privilege sets can bring those concerns up to the committee for consideration. They can contact the chair of their department, or the president of the medical staff. Separately, if the labor unions have any concerns, they should discuss these concerns with the hospital administration. Dr. Nguyen spoke with RNPA leadership, and RNPA leadership can bring those concerns to her. She will then communicate with the medical staff committees regarding those concerns. And I defer any other questions regarding labor unions to Mr. Lorenz.
Supervisor Lee. Thank you, Doctor.
Yes, thank you very much for the report and explanation. And you mentioned that there is, among the issue for the nurse practitioner on these skill sets, the approval, there has been no request to add them to the list. When you say no request, as in there's been no contact from any nurse practitioner or from the union's leadership at all? on the request?
No contact that has made its, no request that's made its way to the committee.
Okay. And I'm just dumbfounded in a way because obviously we heard it from the representative from the RNPA, and that's why I thought that was an issue that has been brought up, and I just want to make sure that there's communication both ways. But if they have not made the request, I certainly would want to make sure that, like she said, that if this is something that needs to be dealt with, I think the communication with hospital administration and this committee you talked about is important with the RNPA leadership. So I just recommend all parties to communicate if there are these future issues in the future before coming to the board. Thank you.
Thank you.
Thank you, Doctor. Thank you, Supervisor Lee. I believe we have a motion on the floor, Madam Clerk, which is to go ahead and approve the privilege sets. Did I get that right, County Council? I did. All right. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. Doctor, thank you for being with us, and you have your approval.
Thank you, Supervisor Simitian and Supervisor Lee.
All right, that takes us to item number 5 on our agenda. Item number 5, of course, is the report on Child and Adolescent Psychiatric Facilities, BHS Center on the Santa Clara Valley Medical Center campus. And who is going to present on this item?
Good morning, Supervisor Simitian and Supervisor Lee. Doug Koenig, Deputy Director for Capital Programs. I do have an update to the report and also can address the question from last month's meeting regarding what are the specific impacts of weather on our project. I'm going to go ahead and share my screen, hopefully. And let's see if I can get this right. And display duplicate. So hopefully you can see the full screen now. An update this morning, as of 8:30 this morning, SBAY announced that they would be complete with their demo and excavation work and be ready to turn the site over to WebCore effective February 16th. So our intent is to issue a notice to proceed to WebCore this week with the start date of February 16th, 2023. So we missed our planned projected date of February 1st, but it was not without good justification, that being the heavy rains that we experienced over the past 2 months. There have been 20 days of rain, significant rain, and the construction tasks that impacts were the soldier pile installation, which is installed with very heavy equipment. It needs to operate on sound ground because the piles need to be installed plumb and properly aligned. The site grading, in this case, we needed to raise the site outside the area of the excavation for anywhere from 2.5 feet to 4 feet. And you cannot do that if you don't have a solid base to work against. And the mud, when the site is muddy, you cannot do that. Installation of lagging, because the retaining wall was not designed to support surcharge loads from heavy equipment, such as the dump trucks and the heavy compaction equipment. The lagging could not proceed until the grading was complete. This is what we were faced with, or what the contractor was faced with after they started the installation of the soldier piles. In order to be able to proceed in this area, the contractor graded the site to allow for drainage to collect at the northwest portion of the site. All right, and for every significant rain event, this is what developed on the site, and that's the northwest corner. That covers about 30% of the site, and it's about 2 foot deep. So every time the contractor experienced one of these significant rain events, it would take the contractor approximately 3 days to pump that water off because they're not allowed to discharge it directly into the storm drains. When they're done pumping it off, they get they get this situation where if you look at the area outside the perimeter of the excavation, you see the mud. So, you know, the options there are to scarify that, let nature take its course and let the water evaporate, or in the case of what this contractor did in order to expedite this project, he actually scraped the mud off of that site, piled it up, hauled it to a temporary location, because not even a landfill will take mud. Once he gets rid of that mud, then they can go into production. And what you see here is the excavation of the basement area proceeding at a rapid pace. At the top, where the tunnel was excavated next to the RSC, they are installing the lagging, and you can see around the perimeter of the site, they are spreading the dirt, compacting the dirt. They're also stabilizing the dirt with a lime cement mixture. And when they do that, this is what they get. This is a recent picture taken Monday. The excavation, the bait is already complete down to the base of the excavation. The pile of dirt you see there is needed for the ramps to gain access for heavy equipment. You see that they're installing tiebacks on the bottom right. They're doing a little bit of lagging. The lagging was 99% complete. They're doing lagging at the top right. And you can see outside the area of the excavation, you can see where these areas have been brought up to the proper grade for the sub base and the ground floor slab. And not only is it to the proper grade, it's been stabilized with lime, so that now even if it rains, it's not going to set them back. With that, I'll stop sharing my screen and ask if you have any questions.
Supervisor Lee, I do, but let me defer to you, sir.
Yes, thank you for the report. And as we have experienced, there's a lot of heavy rain and has caused supersaturated soil conditions. What type of construction issues do we need to be aware of given the current condition? And what type of delay do you think this would cause?
Well, right now, I mean, they've pretty much conquered the weather portion. The first thing that Webcor is going to do, if they don't ask SBA to do it first, is they will also do the lime stabilization of the base of the excavation. And once they do that, then there shouldn't be too many obstacles due to weather as they move forward.
In the near construction management report, can you tell us the significance of having these three critical paths to the final completion?
Yeah, well, three critical paths. The one thing about that, I mean, one of the critical paths, of course, was for SBA to complete the site preparation, and then Webcor needs to go right into the drilling of the piers and the placing of the cages. You know, so that's critical. Getting the shop drawings approved for the reinforcing cages for the foundation, and that's happening in parallel. And I think the third critical path was. I don't have that in front of me, but I guess the whole point is, if any one of those paths slip, then that would result in an overall delay of the project. But at the same time, it would create float in the other two parallel critical paths, because now when you have three critical paths, you're trying to get to the same point, and there's no slack in that schedule. So if that point slips out, then essentially you're down to one critical path. So it just means, I think Webcor has just set it up that way, that there are some things that were out of their control, like they could not control when SBA was going to be complete. They cannot control HCI and our design team as far as when are they going to get the shop drawings, because they need those and they need to get them to the fabricator. Likewise with the drilled piers, again, a lot of those things are out of their control that needs HCAP approval. So I believe that's why they presented everything that way. Because they're, with the way things are with an HCAP project, they're not always in complete control of what they need to be in control of.
Okay, that's all the questions I have for now. Thank you.
Thank you. Let me ask, do we have representatives from Veneer and/or Harvey Rose present? Ms. Solov, is that you approaching us?
Good morning.
Good morning. Let me just ask first, given the extraordinary weather conditions of the last 30 to 60 days, is it the assessment of Harvey Rose and Veneer that progress has been, quote, as it should be under the circumstances? I guess that's the question I'm trying to ask.
I think I heard your question. It's a little soft, but we have.
I'm sorry. My question is, given the circumstances of the last 30 to 60 days, is progress on the project as it should be? That's.
And I believe we have Anthony Foster Davis from Veneer on.
We do. He should be able to open his microphone.
Yes, I'm present.
I'm going to let one of you decide who should best answer the question. Thank you.
Yeah, actually, considering those weather impacts, the contractor actually made great progress, is ahead of what would have been impacted. They had 20 days of rain. Right now, they're only showing 10 work days behind schedule due to that. So they made significant progress during this process.
All right, thank you. And my understanding is that there is a 90-day schedule currently guiding our expectations. Is that
Correct. They submitted a preliminary schedule. It covers the first 90 days. For the most part, that's getting through the submittal process and some of the foundation work as well.
And does that schedule look
Reasonable?
to you? And then I have a more
Definitely for the first 90 days, it definitely was reasonable. Once we get the baseline submitted, we can get into more detail of the schedule.
Okay,
And provide
and forgive my lack of tact here, but does it also look believable? And I'm asking that question very pointedly because, of course, we had a long period of time in the conversations about this project where we had representations about the timeline that ultimately proved to be wildly off the mark.
Correct. For the first 90 days, yes, it does look like a legitimate schedule.
Thank you. And then my understanding is that the expectation has been that we would have I'll call it a complete schedule, understanding that events intervene, by mid-March. Is that still the plan?
That is my understanding, yes.
Ms. Solov, is that your understanding?
Yes.
Mr. Koenig,
Yes.
are we expecting that plan, that timeline still arriving mid-March?
Yes. And now that the NTP has been will be issued, they're contractually obligated to submit that.
All right. Is that a timeline that we could then incorporate in our discussion at the March Health and Hospital Committee meeting, which I believe is scheduled for March 22nd?
I believe so.
All right.
I mean, we're certainly asking them to, to try and make up these days, to look at what they can do. Now would be the time to do it when there's going to be a limited number of contractors and subs on site. The potentially, with the steel erection, that might be a good period where they're the only sub on site. That hopefully they can make up some days.
All right. Mr. Santiago and Dr. Smith, I am, even after all my years back on the board, I am sometimes amazed at the sort of the reverse timeline of getting items submitted to our committee, given the screening that they go through before they arrive here. So if we can just ask that no matter what it takes, we have that timeline at the March meeting rather than lose another month to even look at a timeline. I would appreciate it. Ms. Santiago, does that seem to work for you? Dr. Smith, does that work for you?
Yes.
Thank you. All right. Mr. Koenig, does that work for you?
Yes.
I don't know what the clerk's term of art would be, but if you have to yellow tag some additional information, she's nodding, like after 10 years, I've got it finally. If you have to yellow tag some information to make sure it gets to our committee and thereby to the public as well, that'll be important. And then Ms. Solov and folks at Veneer, I'll say thank you to you for continuing to provide the oversight function that we've described. Anything else before I ask for a motion from Supervisor Lee to simply receive the report? Last call. We have no speakers on this item, so Supervisor Lee, if you're ready to offer a motion to receive.
Yes, so moved.
Motion by Lee, second by Semidian. Clerk will call the roll.
I'll just confirm that there are no speakers online. Vice Chairperson Lee,
Aye.
Chairperson Semidian.
Aye. Motion carries unanimously. Thanks, everybody. Appreciate your efforts to keep us on time on that one. That takes us to item number 6, and we're going to hear from our Public Health Department about the status of COVID-19, and this report is now, as I understand it, going to be a report we have here at the committee level on a monthly basis rather than at the full board, as had previously been the case. Is that square with everybody else's understanding and expectation? Shall I turn to you, Dr. Cody?
Yes, good morning. I will give you a brief report and then happy to answer any questions or enter into any discussion. So on the first slide, I just wanted to start with sharing COVID wastewater concentration. And as you recall earlier in the pandemic, I always started out with the cases. They don't really mean much anymore. So that's why I start with showing you our wastewater. This is straight from our dashboard. Just want to highlight a couple things. One is our great good fortune to be one of the only counties in the country with both longitudinal and comprehensive wastewater data. We have 95% of our population under surveillance with this method, and that enables us to see trends, whether the COVID rates in the community or the sort of your risk of exposure, whether it's rising or falling or staying the same. It also enables us to track variants, so to pick up if there's a new emerging variant, and also to see what might be driving waves. So for example, in some of our sewer sheds, we have XBB. There's so many variants, I won't talk about all of them, but this is one that's quite transmissible, and that seems to be picking up steam in both Palo Alto and Sunnyvale, and then picking up steam in the other sewer sheds. On the next slide, this breaks out by sewer shed the case numbers in green and the wastewater in red, so you can really see how far apart they are and why we don't rely on the cases anymore. Two little things that I wanted to point out, and you can see it on our wastewater dashboard today, and that is that in all sewer sheds, we sort of are starting to flatten at a high plateau, and in San Jose, things are looking like they're rising again. It's a little early to say whether that's going to be sustained, but since San Jose is large and covers about 75% of the population, I watch that one most carefully because it has the least noise. So that's just a sign that things may drift up again. In the next slide, just wanted to show ultimately how this all translates into the number of county residents that die each week from COVID. I mean, you can see the winter wave reflected in the small bump. And I wanted to just remind everyone, while in the first and even in the second winters, our long-term care facilities were really devastated, that's not so much the case anymore. The dark blue are people who lived in long-term care facilities and died of COVID. Other things to note, for the most part, in the last 120 days, most people who are currently dying of COVID are over the age of 60, and in fact, 45% are over the age of 85. So it's really mostly impacting the elderly. And in the last 120 days, the trends have also changed in that whites are disproportionately dying of COVID as compared to their proportion of our population. The next slide, I wanted to give you a sense of, so our, as I've said so many times, staying up to date on your vaccination is really one of the most important steps each person can take. This shows the percent of people who are eligible and receive their bivalent booster by city. And this is a pattern that we've seen throughout the pandemic, in that the rates of vaccine uptake are much higher in the north and western parts of our county and lower in the southern and eastern points. So the lowest bivalent booster uptake is in Gilroy, and the highest bivalent booster uptake is in Los Altos Hills and Los Altos. And in the next slide, you can see this broken out by age. The good news, I suppose, is that in the older age groups, the uptake is higher, which is good, since those are the age groups that we most worry about because of the higher risk of death. And in the final slide, just a few updates for current challenges and what might be around the corner. So while our bivalent booster uptake is just a little north of 30%, which isn't great, it's still much higher than what we see in the state and the country, where it's around just less than 19 and close to 16 respectively. As far as what's next with vaccines, what we know so far is what we learned from a discussion at a recent subcommittee of the FDA. And while they didn't, there's no final decisions having been made, this committee voted in favor of harmonizing the vaccine strain, which means that rather than having the initial vaccine for a primary series and then you get boosted with an updated, you just use that updated for all doses. And also a discussion about a system similar to we have to influenza, where you look at the data in the spring, you create updated vaccines, and then you make them available in the fall at the time, so that there'll be high vaccination rates for the winter when there's so many other respiratory viruses. But no final decisions or commitments have been made as yet. And that is all I have to formally present, and happy to answer any questions.
Thank you. I do have questions, but let me defer to Supervisor Lee. And Mr. Savage, do you have a hard copy of the slides handy that you can share with me now?
I don't have them handy, but I can.
Please do.
Thank you very much, Dr. Cody. Good to see you in person. On the watershed, the sewer shed, excuse me, numbers, I think, as you mentioned earlier, is certainly far more helpful these days because of the fact that the case numbers is no longer very accurate. As many times people who contracted COVID really does not report to any medical systems, right? And the amount of testing we've done have significantly less than what we used to have. So I completely applaud that effort of those who's working on keeping our sewer shed numbers accurate. That being said, looking at the case numbers on the rate of vaccination, I think it's actually quite indicative of the amount of folks throughout our county of 2 million people that those in Gilroy and San Martin versus those in Los Altos Hills and Los Altos is more than double in terms of those who have taken the bivalent vaccination. And I am concerned, I guess the question is that due to people's individual opinion of the vaccine, or is it more due to the fact that there's accessibility issues because there's certainly no shortage of bivalent vaccine for a long time, right?
Yeah, at this point, my sense is that it's not a matter of barriers to vaccine, in that vaccine is accessible to all, either at county sites or at retail pharmacies, or from individual providers. and there's certainly been enough time for people to get vaccinated. I think the barriers are different, and they may stem from indifference, pandemic fatigue, feeling that the risk is over, another shot isn't needed, issues such as that have been very difficult to address.
And as we have previously tried to use different method to entice our residents to get the vaccine. For example, I remember we were using boba drinks and whatnot for the younger population, the teenagers, for example. My question here is, do you think it still makes sense for us to try to attack that population that has not been receiving the vaccines, and through the geographic numbers, whether we should try to outreach more to the South County, for example, to make sure that Gilroy, San Martin, Morgan Hill will be able to receive these vaccines to make it more available, make it so that we can increase some of these numbers.
Right. To be honest, the groups that I would be most concerned about are people ages 50 and up. Most critical for them to be up to date and have their bivalent booster. And strategies to reach groups like that, particularly those living in long-term care facilities, is to continue to support the long-term care facilities in connecting them to vaccination resources. And so in our COVID prevention and control program, we still have a group that does regular outreach and works alongside the long-term care facilities. So I think it continues to be a multi-pronged strategy. Part of it is communications, and part of it is higher touch direct work and trying to understand what barriers are to particular higher risk groups.
If I can lean in for just a moment, excuse the interruption, Supervisor. I'm going to ask County Counsel's office to keep me Brown Act compliant here. I have a draft referral on vaccination strategies going forward, which I have briefly, like 60 seconds worth, discussed with Dr. Smith. And when I have polished it a bit more, if you like, Supervisor Lee, I will come to you and ask you to be a joint author on the referral. And Mr. Press, have I stayed within my Brown Act rules on a two-person committee here? And
I believe so.
all right, thank you. All right, I just wanted to sunshine that fact so that if you were wondering where do we go from here, that there was in fact a path for a discussion by the full board on sort of where do we go in this next chapter.
Perfect. And earlier I heard this. I wasn't sure. I hope I'm not sure if I heard this wrong. You mentioned, Dr. Cody, that 45% of those who died in our county are 85 years old or older. Is that what you said?
Right. If on the dashboard, you can see deaths broken out during the whole pandemic and in the last 120 days. And if you look at the most recent data, it shows that about 45% of the deaths over the last 120 days have been among people age 85 and up.
Right. So we're talking about close to half of those who died who are over 85 years old. So it certainly really shows that this COVID risk is extremely high on those who are older, and especially those in over 80, 85 years old. So I guess that's the other idea I'm thinking about, like you said, long-term care facilities and any other ways that we could encourage those on that age group to make sure that they do the best they can in terms of getting these bivalent protection.
Right. I will note that among those who are older, vaccination isn't enough. So many of those who are older who have died have had their primary series, and many of them have even had their bivalent booster. And that's why, even if I am tilting at windmills, I continue to advocate for layers of protection, which includes masking indoors when COVID rates are high. And that's especially if you live with or have a lot of contact with someone who might be at risk despite being up to date on their vaccines.
Right. Right now, there's been potential changes in the federal policies on the payment of these vaccines. And we have certainly seen some pretty high, very expensive proposals that have been given by some of the companies like Moderna and Pfizer, about over $100 for each dose as being requested. I wonder if there's any value for us to tell folks that, hey, get your vaccine while it's still free. Because I think whether that would be one way to entice folks, I just want to throw that out as a potential idea out there.
Yes, and when we announced that our county mass vaccination sites would be coming to a close at the end of this month, that is one of the points that we emphasized, is that they're free, they're easy to access at the vaccine sites, and there's still time. After that, of course, insurance will cover vaccination. The county will continue to serve anyone who needs vaccination, but that still leaves a proportion of the population that will struggle.
Right. When it comes to getting COVID coverage, like for those who have been infected with COVID, I believe the federal government is still paying for all the treatments. Is that correct?
I believe so. One challenge is that many of the treatments that were viable during earlier waves with different variants don't work anymore. So Paxlovid is really incredibly important, and it's easily available but underused.
So right now, Paxlovid is proven to be effective, and and we have no shortage of it, right? In our county,
correct.
certainly that's something that's easily accessible. So something we may be able to try to advise folks. And then in the future, assuming that the funding from federal government might start to dwindle on this issue, there will be a possibility that those will no longer be free either. Is that the concern as well?
I don't have up-to-date information about treatment and funding of treatment, is honest truth. There may be someone else here who has more up-to-date information than I. Anyone happy to lean?
Yes, good morning, Supervisor, via the chair. The inaction by Congress to approve the president's proposal to continue funding the COVID and the pandemic response has limited, of course, the ability of the federal government to provide reimbursement and to purchase the vaccines for the manufacturers. So that's what you're referring to, which is now it's going to go back to the manufacturers and their pricing, and then, of course, it's going to increase, tenfold.
Mm-hmm. Right, literally, because I think the vaccines were under $20, those the way the government used to purchase them at, and now we're talking about over $100. So
Correct.
right, okay. The last question is about telehealth, and would there be any type of affecting telehealth access to COVID treatment or consultations in the future? Do you see that?
So I'm going to invite Renee to lean in again. There are a number of flexibilities during the declared state of emergencies that will go away, and I honestly can't recall whether telehealth is one.
Yes, we have we're gathering details in terms of what stays and what goes with the emergency. There's a couple factors in it. Even though the federal government has declared that March or the end of an extension of another 60 days post-March, which is May, for the end of the pandemic and relevant legislative as well as funding sources. There's another authority that the federal government has that allows to continue funding the treatment aspects of it. Mm-hmm. So as we understand it, the telehealth specifically will stay on for an extended period of time through the calendar year. The state of California, of course, has extended that as well. That's particularly important for the Medicaid population here. So we're going to see ongoing funding for telehealth. There's some variations on the flexibilities for the use of telehealth. Mm-hmm. So some of those details we probably could give you an off-agenda memo to give you more information, so that way we can inform the public in terms of what's really they can continue to depend on, and then, of course, what's going to be the responsibility of insurers.
Great, thank you. And I don't have any more questions, but I actually do have a motion. May I make it to approve to receive the report? But also one other items I'll see if you could look at potentially doing additional outreach in the South County, which include, of course, formerly called DePaul and St. Louis, which is office hours, and we could provide more material, both in language and in English, of course, to the residents over there. So I think that would be one way to try to encourage more folks in the South County to think about getting their bivalent booster, if that's acceptable to Supervisor, assuming Chair Smitty.
I'll second the motion, but with and then I have some questions and comments as well. But I want to offer a cautionary note, and it ties into some of the remarks from Dr. Cody. You know, we're 3 years in. At this point, people know there's something called COVID. They know there are vaccines. They have made their own judgments about what they will or won't do, what they will or won't choose to do. And I think at some point we have to, understand that that's just the case. I don't ever want to be in a position where we aren't reaching out to underserved communities and in ways that are effective. But my own approach as one member of our 5-member board has been what I would call bifurcated between trying to engage folks with more information, more opportunities, multiple languages, but also trying to make sure that folks who are inclined to access the vaccine or the booster have the information they need and the easy access that they need to exercise the judgment that they've exercised. I think at some point you have to ask yourself, is the best public health outcome derived from continuing to pursue folks who've said, I'm not going there? Or is it derived from focusing on folks who have said, I will access the vaccine if it is readily available, and making sure that they have that information? Dr. Cody, I don't want to put words in your mouth, but I sort of thought that was the tension you were referring to.
Well, my sense is that we have reached a degree of saturation.
Yeah.
And 3 years in, I believe that pretty much everybody knows what COVID is and how to prevent COVID and how to prevent severe illness. And people have various reasons for taking actions or not taking actions. And I don't know that we're going to see that much change at this point. We did, the pattern of booster uptake, interestingly, was a little different, the bivalent booster, than the others, in that the others, we had a sharp peak and then it tailed off. Like everyone who was going to get it just got it. With the bivalent boosters, it actually rose slowly and then stayed at a plateau for quite a while, and now has drifted down to really not much. So it took a little longer for people to decide to take the bivalent booster. But my sense is that most of the people who will already have, and barring some news or event that inspires them to make a change, we might be close to saturation.
Yeah. That being said, if there's what I'll call a long tail to the take-up on the booster, this is the reason for the referral that I am referenced earlier, and that I'll reach out to you on before I proceed to the full board. I do think we need to, stay in it, stay at it, and I know you're not suggesting otherwise, with perhaps some adjustment to our expectations about the level of participation. But I think at a more modest level, we want to be there for people who, quote, finally got around to it, end quote, to Supervisor Lee's point, we want to make sure that that happens in areas that are underserved in terms of their access, and make sure that whatever the underlying causes of the lower numbers are, that awareness and ease of access aren't the problem. So, all right, let me ask some quick questions here because I want to try and move us along, mindful of our time constraints today. Dr. Cody, you said you were focusing more on the wastewater concentration because, and I think I have your words verbatim, you're relying more on those rather than the cases, because the cases, you said, they don't really mean much anymore. What does that mean? Because a layperson, I'm going to take you back to my sidewalk office hours, would come up to me and would probably not say, tell me about your wastewater numbers. They'd say, how are we doing on cases? The reason you're focusing more on wastewater than cases is what again?
Thank you for allowing me to clarify. What we want to know, and what we want the public to know, is how much COVID virus is circulating out there. What is my risk of exposure? How do I make a decision about actions that I need to take to protect myself? Sort of like a weather report. Prior, we looked at case rates and case numbers to inform us about that. You'd see case rates rising, you'd say, ooh, it's not looking good, I'm going to be a bit more careful. Or you see them dropping and low and you say, well, I'm going to relax a little. My point is that those case rates don't reflect your risk of exposure anymore, because most people don't, when they're ill, they don't test at all, or they don't get a PCR test, and those are reportable. Home tests are not reportable. And so in order to judge the weather and what your risk of exposure is, you now need to look at wastewater surveillance. And Santa Clara County is extraordinarily lucky in that we have comprehensive and longitudinal surveillance to look at.
Excuse me, why don't other places have that same ability, or do they, and they just haven't chosen to go down that path as early as we did?
There are a number of factors. One, early in the pandemic, academic partners at Stanford reached out and asked if we wanted to pilot with them. Number two, we were able to find grant funding to support it. And number three, the county looked at this and said this is important, and has supported it with general fund. And those three factors have not been in place for other communities. So we have support from you all, and that is why we still have wastewater surveillance.
Yeah, even speaking as a layperson, I thought it was fairly obvious when you and the rest of the team, Dr. Smith and others, came to us on the wastewater capture. I don't mean this in a flip way. I mean it in a very sort of objective way. Easier to capture the wastewater than it is the case data, for lack of a. But part of the reason I asked the question is because one thing I also know is that every place in the country has wastewater. So I was sort of surprised to hear you say that we were in an unusual and in this case helpful position. Looking at the percent of people who receive bivalent booster doses out of the eligible population, the chart for February 2nd, and then the ones by age group, and then the COVID challenges and updates. Again, I'm trying to make sure I'm bottom lining this properly. It looks to me like the take-up rate on the booster is literally twice what it is here in our county, is literally twice what it is nationally. I'm looking at 15.5 nationally.
Correct.
And 32% here. Okay. So that's, quote, good news, even though the number is lower than we would like, and as Supervisor Lee and I have both pointed out, appreciably lower in some parts of the county. I'm troubled, and I gather you are too, but again, I want to confirm my understanding that the 75 and up take-up rate is basically about half the eligible population, yes?
Yes.
Okay. I do find the city-by-city data, which I've asked for before, and your team has been able to deliver very quickly, and I appreciate that, helpful. Is this something we can just get off agenda on a weekly basis?
Yes, I think that would be fairly easy to do because the code's already written. We could produce it
Good.
at whatever interval is helpful.
All right, thank you. When you talked about layers of protection, I think you will recall from some of the earlier conversations that you and I had, and we had in this committee in the earlier days of the pandemic, that I'm sympathetic. I remember the Swiss cheese analogy all too well. I frankly, and you know, there may not be an answer to this because it's kind of a, as I say, a colloquial characterization, but I frankly have never understood why people struggled with the notion of, here are a half dozen things you can do. If you do more than one of them, that's better than doing just one. And if you do more than two of them, that's better than just two. Have you got any, I mean, you know, I know, no, I mean, you and your public health professionals are confronted, it seems to me, with the, all right, in an ideal world, here's how people would behave, knowing full well that we don't live or work or play in an ideal world. So then you lay out this suite of possibilities. Outdoors better than indoor, fewer people's better than more people, farther away is better than closer to one another, masks is better than unmasked, you know, vaccine and boosters is better than not. I mean, there, you know, right there, there's a half. Testing, so you know, is better than not knowing. So there's a half dozen things. Do you have any sense for why people struggle with that part of it? I mean, I think we've discussed a lot about, you know, vaccine hesitancy or resistance, but, you know, what's any thoughts you can share after 3 years on this?
In general, the public health approach is to make the healthy choice the easy choice. So you change the environment to, you create incentives, you remove barriers, you try to create an environment where it will be easier. So for example, if you want people to mask indoors, you put masks at the doorway where they could pick them up. If you want them to wash their hands, you put hand washing stations that are easy to access. If you want people to get vaccinated, you put vaccination sites all over the place, near public transportation and roads. Things like that. So that's pretty standard public health fare. And you educate people, but education is really not enough. They have to know, and it has to be easy. And you all have raised this many times in our 3 years of conversation about COVID. And I would say that our county has really bent over backwards to try to remove barriers and make it easier, and guide people towards something that's going to be healthier for them. But then there are social norms, and those are very difficult for public health officials to influence and change. You know, this is what makes the practice of public health really interesting. I'll close there.
All right, and let me see if I have any more. Oh, you mentioned just in passing, and I want to make sure that I caught it or heard it right, that there's been some change in the race and ethnicity in terms of fatalities. Did I hear that correctly?
Yes, if you look on the dashboard under deaths and compare deaths over the course of the pandemic to deaths over the last 120 days, you can get a little bit of a taste for how it's changed. And what I just wanted to highlight is in the last 20 days, you can see deaths broken out by race, ethnicity, and you can see the proportion of the population and the proportion of COVID deaths. And those have changed. So, for example, now whites disproportionately are disproportionately represented among the deaths in the last 120 days, whereas over the course of the pandemic, that's not the case.
Any thoughts about why that might be?
I would have to look at it, sort of dive into the data to offer any explanations. I don't know.
Can we ask your team to take a look at that data,
Sure.
please, and share thoughts at our next meeting in March, please? This goes back to the issues that, forgive me, I'm leaning away from the mic, which I know the clerk struggles with. This goes back to the issues that Supervisor Lee raised. In the earlier days of the pandemic, when the disproportionality was discussed, it was largely among communities of color, which we were concerned that those communities of color were lacking access to and information about and culturally competent, language appropriate services. And East San Jose and South County were commonly referenced. And I'm just trying to, that then raises the question, why would the disproportionality now be impacting a different racial and ethnic group within the county's population?
We can come back with a little bit in March with a little bit of a deeper dive on the patterns of COVID deaths.
Yeah.
By place and race.
Last question, just mindful of time here. I know you have worked closely and been in touch for these past few years with colleagues in other Bay Area counties, but I'm actually curious about other counties around the state and around the nation that are less diverse than Santa Clara County. And what has that meant in terms of the way our public health department has been obliged to address the pandemic as compared or contrasted with other places that may be more homogeneous in terms of race and ethnicity, or where the diversity that does exist may be very different. It may be black-white, as opposed to the real, mix of languages, for example, and native-born versus foreign-born that you've dealt with here in Santa Clara County.
Yeah, I mean, every public health department has struggled and has seen disparities. I think that our challenge was great, given the incredibly diverse population that we care for here. I could speak for a long time about what made our county's response unique. Just to touch on a few, many our county employees, to a large degree, and certainly the public health department, represent the communities that we serve, which enabled us to access information and ways of working with communities much more easily and much faster, and that served us well. We started out with, our websites were in 5 different languages. We were able to bring that up fairly quickly. I think that was unique. And finally, ours was a whole of government response. It was not just the public health department trying to figure it out. Many of my colleagues did not have their whole county organization wrap themselves around the public health department.
What the heck were they doing?
Well, it wasn't as robust or sustained as, other public health departments had help from the rest of their county organizations. It didn't last as long as ours has, and it wasn't as robust. That was quite unique here.
Dr. Smith, you got an observation there? I'm gonna, forgive me for pointing it right, but I mean, obviously I can only speak for myself as one of 5 members of the board, but I really didn't see that we had any other option. I mean, I didn't see it as a choice.
Well, certainly Sarah would have better access to the public health departments in other counties, particularly in other states. My sense from the administrative perspective is this issue quickly became a political issue, pitting conservative Republicans against Democrats, and the interest that the other political entities had in supporting public health was quite diverse. Even in our state, which is a relatively liberal state, there were public health officers who were, to use a colloquial, hung out to dry by their board of supervisors, attempting to fire them, attempting to change their opinions. There were some counties where it was quite nasty, and that happened across the nation, so that rational minds lost out, and your approach would be rational to say, we really don't have a choice, we have to deal with this effectively like a disaster. That became less than a fulsome understanding by many agencies across the nation.
All right, well, on that not terribly cheery note, Supervisor Lee, we have a motion, includes some direction, and I have seconded, but I see you leaning in. Additional comment or question before we call the roll?
Yes, definitely. I just want to supplement. I certainly agree with what's been said by both Dr. Smith and Dr. Cody. I think being easy, accessible is always one thing. And then the other thing also, of course, is, people have life, right? Jobs, scheduling, and oh shoot, I don't want the immediate side effect. I might be tired or sick for the feeling the next day, right? So, for example, I try to get my shot on Saturday so that Sunday to sleep through and all that. So I think there's so many reasons why people are just not as inconvenient to go get the shot, not because they have the issue of the trust that Dr. Smith was talking about. I mean, a lot of people who already got the full cycle, but they're not getting that bivalent booster just because it's just not so convenient. So I'm just trying to get the word out. And in some ways, it's a reminder. Some call it nagging. And then I use a quick example. I know how important brushing teeth is. And sometimes I get really tired laying in bed. I don't feel like brushing before I go to bed. And then my daughter comes like, Daddy, go brush your teeth. And then what I do, I'm like, shame on me. Okay, fine, I'll go get a brush of teeth. I'm using that analogy as to say, sometimes it's that nagging that actually helps. I know that's good for me, but it's more comfortable laying in bed than do it, right? So that's the reason why I'm thinking having a little bit more additional outreach and that kind of a reminder or nag, or whatever you want to call it, I think would help get folks to say, okay, yeah, I'll go get it. And I think that would, eventually help, because not just for them, it's also for the 85-year-old grandparents and whatnot in the household, that they would save their life. So these are different angles. We could look at, hey, you could get it for free now. It might cost you money. B, is you're also helping protect your seniors in your home. So there are many ways I think we can message this. And I just, we talk about districting, redistricting. I can't help but look at the district, like you look at the ones with the 1, 2, 3, 4, 5, 6, 7, 8 cities that has the highest bivalent boosters, and it's all represented by Supervisor Medium, which means he's done a great job for his constituents, but all joking aside, I really do think that I think that does help. And it's really sad that there's a lot of fake news, and from time to time with speakers coming and just giving us a completely different set of facts about vaccines, and it's distressing. It's freedom of speech. They could say a lot of these things, but at the end of the day, I think if anything we have learned from all this is that we just have to we cannot force people to get a vaccine. We try that from time to time, and that's not really what this country is about. And right now, I think we are getting to the point where we are in some ways leaving this pandemic, and like some people wear masks, some people don't wear masks. You're free to wear when you feel it's safe to do so, and I think that's. I mean, I'll try to do a better job myself, Dr. Cody. I'm not wearing right now, but at the same time, I really do think that. Further outreach on the vaccination is something that as our county, as public health, we really should be doing. And so if that's something that's doable, I would encourage us to continue reminding people, like reminding me to brush my teeth. Thank you.
And thank you for the annual reminders about the flu shot, Dr. Cody, which I've taken to heart. I see Mr. Press before we call the roll.
Yeah, sorry, just a question about the motion that's pending. I'm a little concerned if it's more than just receiving the report in terms of giving direction to staff, in terms of...
I will
It's a recommendation.
endeavor to recast it as I announce it and make sure that it works for the maker of the motion. My understanding is, and I think we may have speakers on the phone, so we want to take them as well before we vote, that the motion on the floor is to receive the report, which is the recommended action, and to request of staff that they take an additional look at the lower levels of participation in some parts of the county as indicated by the materials we have, and consider additional outreach possibilities to make sure that those areas have every opportunity to access the vaccine, including but not limited to multilingual materials. Did I capture that request correctly, Supervisor Lee?
But I could have said it. Thank you.
And then for the minutes and for the record, I heard Dr. Cody say, yes, we're happy to do that, even though it was only a request and not a formal direction from our full board.
Very well.
Dr. Cody, did I capture that correctly? There you go.
Thank you.
And turning to the clerk, do we have how many speakers online? We have 2 speakers, and we would invite each of them to speak for up to 2 minutes. Go ahead and access the first, if you would.
Our first speaker is Karen D. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, hello, my name is Karen Dakampari. Thank you for letting me speak today. First of all, I'd like to mention, you were asking why don't people trust public health? Well, because there's been a complete lack of honesty. There's several things that can lower COVID death risk that are completely free, such as vitamin D, which you get through the sun, weight loss, exercise. This is never even mentioned by public health. And then second of all, there's no mention of the increase in non-COVID deaths. There was even an article in the Mercury News about a week ago saying there's been an epidemic of non-COVID deaths that is completely unaccounted for by your public health department. The Cochrane Library, which is the most esteemed institution in this country probably, recently did a review on masks and came to the conclusion that they do not work to prevent COVID infection. And also, the COVID vaccines, after a short interval, also do not prevent COVID infection. The CDC director, Dr. Walensky, got a bivalent booster, and then a month later, she came down with COVID. So it's not preventing infection. And as you heard from the public health director, it doesn't prevent death. Many of the elderly who died were fully vaccinated and boosted. There's a problem that our colleges in Santa Clara County are requiring 3 injections and even masking in many places when college students are not at risk for severe COVID infection. It doesn't prevent infections at all, and it carries serious side effects such as cardiomyopathy, blood clots, menstrual disorders, decreased sperm counts, cancer, and several neurological problems.
And our next speaker is?
Ken Yu. You'll have 2 minutes to speak.
Yes, hello. I'm Ken Yu. I'm a practicing physician in Mountain View. And I'm speaking today because I have a college-age son who's interested in going to De Anza, but they have a vaccine mandate in which, you know, the students are supposed to get vaccinated and mask on campus. Now, he in looking at the data himself, a very smart young man, concluded that he was in a very low-risk group, given his age and his lack of comorbidities. So he decided not to get vaccinated. And, you know, a reasonable person might decide to do that, especially considering the fact that in 2020, before the vaccine, he contracted COVID, it presumably had some cell-mediated immunity from that point of view. You know, when you look at Pfizer's own data that they published in the New England Journal of Medicine, particularly in that age cohort, his relative risk reduction from getting vaccinated is probably less than 0.1%. And so the conclusion that he, you know, came up with was that you shouldn't do any medical intervention that has no benefit to you, regardless of the fact that there might be some low risk of side effects like myocarditis and whatnot. So, you know, in echoing Supervisor Simitian's point that, you know, by this time, 2023, the landscape around COVID-19 is different from 2020. We're no longer in a crisis in which, you know, deaths are outpacing our capacity to staff our ICUs, that it makes sense, particularly in low-risk categories, to not, you know, use coercion, such as preventing education for young people, you know, to advance any COVID public health measures, but to in fact focus more on high-risk groups such as the elderly. Okay.
Our next speaker is Joy Seed.
Before we go to that next speaker, just for the committee, we had two speakers who raised their virtual hands, and we heard from them. Then while they were speaking, one more raised their hand. We're going to take that one more speaker. Want to make sure we let folks speak if we possibly can. But at that point, we are going to cut it off on this item and go to a vote. And folks, if you are listening virtually and would like to participate, please let us know early on so we can manage time accordingly. Thank you, Madam Clerk.
Thank you. We'll open the microphone for Joy Seed. You'll have 2 minutes to speak.
Okay. Hi, thank you for taking me. I thought my hand was up before, by the way. So I want to point out a study that was done by the Cleveland Clinic. You may be aware of the Cleveland Clinic. It's one of the most prestigious medical facilities in the United States. People come there from all over the world, and they have approximately 51,000 employees. So they have been keeping statistics, actual data, since the start of the vaccinations. And so they know for each employee how many vaccinations they have, and they know how many employees have not been vaccinated at all. So they did a study to see, what the outcome of vaccines were in terms of preventing COVID. And they were very shocked to find out for their vaccinations that, well, before I tell you that, just want you to know that they know for a fact how many employees were out for getting COVID. So they have, because they're their employees, so they have all this information. So the employees who got, and they did this, this data is reported proportionally. So the employees who got no vaccinations had the least amount of COVID. The employees that got one shot had more COVID than the ones who were not vaccinated. The employees who had 2 vaccinations had more COVID than the ones with 1.
All right, and that was our last speaker. Thank you to you all. I believe we are ready for a vote on the motion, which has now been Brown acted into appropriateness. Call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. All right, motion carries unanimously. That takes us to item number 7, the paramedic training item. And who's presenting on that? And let me just say, important item, one that I certainly have pushed on, but we're a little behind schedule. That item, last item took a little more time. than initially anticipated, so let's try and do this one as quickly as we can while still doing a comprehensive job.
Yes, and good morning, Mr. Chair and Supervisor Lee. I wanted to make just very quickly 2 points. One of them is introduce John Blaine, who's the interim director for the Emergency Management Services Agency, who's going to be part of the presentation, along with Dr. Miller, who you're very familiar with in terms of the medical director. In the staff report, we provided very detailed information about both the response times historically. This is pre-COVID for 2019 on a 12-month basis, as well as the current data that we have based on your request to give very thorough and detailed information about that. The other piece that we've also provided for you is the volumes that in terms of transports as well as calls that we were getting for 911 and EMS. So I'll turn it over to John and then Dr. Miller for presentation.
Thank you, Renee. Supervisors also invited Brian Hendrickson. He's the regional director for AMR.
Let me just indicate, and folks, I really do struggle to manage the time because we have a pack a lot in. We have the PowerPoint, and we got it in advance, which we appreciate, and that meant we had a chance to look at it, and I know my colleague and I have both looked at it. So I think I'm going to ask you to forego running through the PowerPoint. That's the first thing I would say. Second thing I would say is I'll just indicate, as someone who's been pushing on this issue for a bit now, I thought the report back looked good for the most part. I thought it outlined the short-term problem relatively clearly and identified concrete steps to turn things around in the near future, which was what I was looking for, so thank you for that. And I also think it was important that source of funding was identified as well in terms of the exercise. I think an area I would encourage you to explore and keep us informed on a little more fully perhaps is just the strategy for providing paramedic training programs with internship placements at hospitals and on ambulances as we go forward. I know you've had some conversation about that, and I believe with my office as well. Want to stay on top of that. I know we have a letter from the folks at Foothill who I think are trying to reinvigorate their program. That's probably the best way I would describe it. So with that said, is there anything else you would like to add? And I don't mean to cut you off if you have a major headline you want to make sure you share, but I wanted you to know the materials had been received, reviewed, and that I had opinions about them, which I've just shared with you.
At this time, we have nothing else to add to the ledge file.
All right. Anything else? Dr. Miller? Okay. Okay. The one other exhortation, since I have everybody's attention here, is this has to be fixed. Okay? This is not some, I mean, Dr. Miller, I think it was before your time, but your colleagues will tell you when the challenge was with folks at San Jose Fire Department as first responders, I was a dog with a bone on that one. And I intend to be a dog with a bone on this one. So it's got to get fixed. It's important. I am going to take you at your words that you understand the importance of getting it fixed, and we'll take the steps necessary to get it fixed. But other than that, I will simply ask that the committee, through a motion from Supervisor Lee, take the recommended action, which is to receive the report. Supervisor Lee?
Yes, so moved.
All right. Thank you, thank you, and thank you. Let me check with the clerk. I have no cards for speakers in the room. Do we have anybody online? We do not. Then please call the roll.
Vice Chairperson Lee?
Actually, I do have one quick question, if I might.
He Columboed us, as we say in my office. Okay.
One question I have is, there are 5 short-term staffing mitigation strategies listed in the attached presentation from AMR that we have. Can you provide more detail on these 5 strategies of how they're working and if it's working?
We can. We'll work with AMR to do that.
And then Supervisor Lee, how would you like that shared?
I think it would be helpful just to give us the verbal report's perfectly fine. If not, what we could do is we could even bring it back to us in the next meeting. That might save us some time.
How would you feel about having it be a written report shared off agenda and then also included at our next meeting in March.
That would be perfect.
Can you manage that additional written homework assignment?
We can.
Thank you.
Great, thank you. Then that's all I have.
Motion by Lee to receive the report with the request for follow-up as indicated. Indication through the clerk that the request for additional information has been acknowledged and agreed to. I will second. Please call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Semidion?
Aye. Motion carries unanimously. Thank you. Stay at it, folks. Thanks. That takes us to item number 8. And who is the presenter on this one?
Yes, and once again, myself,
Thank you.
Rene Santiago, Director of the County Health System. This is an update on the critical issue that you have not only championed for us, but also outlined some high priorities in terms of mental health parity. If you recall from prior work, we had identified at least 3 aspects to parity. This is upon the observation by the board that parity is the law of the land. Why isn't it happening in terms of the real experience from clients or patients in terms of getting immediate and timely access? So we've broken down into 3 different aspects of it. One of them is the policy issues. What is it that it's happening or not, maybe not happening from a policy perspective that translates that law and regulation into very specific actions? And so Amy Carta from our health system has been facilitating a stakeholder work group that includes all the other major providers in our community in terms of not only engaging them, but also seeking some of those answers. And so we have in this report a latest update in terms of that stakeholder process. And again, involves not only hospitals, providers, as well as insurers, but also legal advocates, as well as consumer representatives. The second aspect that we're reporting on is the West Valley, which is one of the issues that particularly Mr. Chair Semidion, but also the full board identified as a gap in our system. We've identified, as you recall, the target population there. We identified some of the list of the providers that are currently listed in that community that theoretically are contracted to provide services. And when I say contracted, it could be by a variety of different entities, not just the county. Obviously, we have most of the contracts throughout the county in Santa Clara here, but it also involves the managed care plans, which are responsible for mild, moderate conditions when people face depression, anxiety, those kinds of situations or conditions. And therefore, we have a list of those providers. Now, in going through that list of those providers, as I mentioned last month, we've identified that not all the providers are comprehensive providers. In some cases, some providers only work on very limited capacities, on only very limited hours. Some of them focus on children only. Some of them don't do any adults. Some of them just focus on some area in terms of case management versus treatment and a variety of other modalities. So we're still vetting that list of providers, and we'll get, hopefully, through our needs assessment and identification of gaps for West Valley, we'll be able to give you a much more updated and validated list at our next report, which my understanding, it's coming up in April as part of our Health and Hospital Committee agenda. The other aspect that we have here, which was a referral by Supervisor Semidion in terms of, and adopted by the full board, which was expansion of our trust outreach teams into the West Valley. And so we give you an update on that as well. I think your concern, Mr. Chair, was that we didn't miss the boat in terms of the budget, and just happy to report that Dr. Terrell and Dr. Poon, who's here as well, representing her today, have recommended that as part of the MHSA planning process, and we're including that as part of our fiscal year budget recommendation to the county executive for 23-24. And so therefore, that concern that you had that we might miss the opportunity is actually, this is the report to confirm that it's actually included in it. We do expect a full comprehensive presentation on trust coming up in April as well. So this will just give you an update on status on that. With that short answer and comprehensive report, we just wanted to be available for, if in case you have any questions at this point.
Thank you. Before we go to questions or comments from board members, we do have some community members who have submitted cards, and I don't know if we have folks online. We do. We have two. I have two. Let me just ask folks online, because we are struggling a little bit with the time today. If you would like to speak, please indicate now, because we're going to hear from two speakers in the chamber, and then we're going to cut off the number of folks online. So please let us know now. We have Paul Soto, followed by Sarah P. And forgive me, Sarah, but your handwriting on that next letter, I struggled. So I'm just going to let you introduce yourself when the time comes. Mr. Soto, the floor is yours.
Thank you. Paul Soto from the Horseshoe. I wanted to talk about equity within the context of mental health. There has not been an assessment on what has happened generationally, mentally, with the offspring of the children that experience the abuse inside of Santa Clara County Schools, San Jose Unified School District, Eastside Union School District, and Alum Rock School District. I do not speak Spanish today because of the way that my mother and father were treated in Santa Clara County, in San Jose Unified School District specifically. What that did generationally is I inherited from my mother a sense of inferiority that was not hers. In turn, certain values and certain kinds of behaviors inside my home were translated through the family units. This is how it's passed down. That's what the mission system was about. This dates all the way back to the mission system. Why do you think we have the border in San Diego? Because it locked in the 21 missions. That's why we have it there. So this concept of colonization that has manifested in different ways throughout this county specifically, has never been examined properly. Now, if we don't examine that, what we're doing with our mental health system is this. We are putting a cap on top of a cavity. You don't go to a dentist and do that. What you do is you go to a dentist, and what does he do? He drills that out first. Drills out the decay, the cavity first, then caps it. That promotes healing. We haven't done that yet. I want to drill out this cavity, and that cavity is racism in the way that it is manifested generationally in the school systems. Thank you.
Thank you. And our next speaker, please come forward. Welcome.
Thank you. My name is Sarah Prabhu.
That's an R. All right, thank you.
Yes. And I'm here from NAMI, Santa Clara County. I'm here to read the letter of support from our Executive Director, Rovina Nimbalkar, giving our support to this initiative. We are very thankful to Supervisor Simitian for taking on this effort to educate the public on mental health parity. Mental health parity legislation, such as SB 855, is the most advanced in our country. Early intervention is critical to recovery. Many NAMI members on private insurance have found it difficult to access mental health care. This presentation will help many people understand how to receive medically necessary treatment in a timely manner. NAMI Santa Clara County is honored to be a partner in creating this mental health parity presentation. Thank you.
Thank you very much. Let me turn to the clerk and ask first, how many folks do we have? We still have two. All right, these will be our final two speakers, just in case anyone is listening, and we invite them to speak for up to 2 minutes. And thank you, Ms. Prabhu. And now I have the R properly noted.
Our next speaker is June Klein. You'll have 2 minutes. Please go ahead.
Hi, everyone. June Klein. I'm a member of the Santa Clara County Behavioral Health Board, and I'm also a member of the Mental Health Parity Work Group. And I just wanted to say that enforcement, in my opinion and my experience as the managing healthcare benefits programs for a nonprofit for over 20 years is very difficult. And what we're trying to do is look at best practices around the country on how best to educate the employees and the general public on how to advocate for themselves. So we're arming the people in our county with information on how to access care and services, how to understand their rights, how to understand the law, where to go for additional assistance, such as NAMI and Bay Area Bay Legal, and then also the resources and information that are available through the county and other places. So I very much support this initiative and hope we can make things better for everyone. Thank you.
Thank you.
Our next speaker is LAL Zoom. We'll open your microphone. Please go ahead.
Hello, my name is Barbara Texador. I'm the managing attorney of the Legal Advice Line and Health Consumer Center at Bay Area Legal Aid. I am also in support of this initiative. I manage the Health Consumer Center. This is a department at Bay Area Legal Aid that provides direct legal services and outreach in order to increase access to health care by removing legal barriers. So our attorneys provide services in helping people enroll in health plans and then getting access to health care by doing complaints, appeals, anything across Medi-Cal, Covered California, or private health insurance. And so this initiative is very important for us because it is part of our mission to educate the public about their legal rights and also enforce those rights through our legal work. And we serve the entire Bay Area, so Santa Clara County is one of the counties that we serve. And we are also participating in the mental health parity work group and helping develop the presentation on legal rights and also helping develop tools that will educate the public on what steps that they can take to get access to mental health care. Thank you.
Thank you very much. Mr. Santiago, anything else?
Other than thanking our stakeholders, quite honestly, because they've given us the patient and the provider perspective so that, in fact, we can be responsive to your request to develop those tools and resources when we go out there and do these regional forums. Thank you.
All right. I've got two questions, one for anybody who wants to lean in. That could be you, Mr. Santiago, or somebody else, including counsel, and then I have one that's very specifically directed to counsel. So I think, you know, Dr. Smith and Mr. Santiago, you've been very sort of clear from the day one when I raised these issues that there were some limitations on what we could do to actually, forgive me, bring the hammer down and make this happen. And so we've got this sort of multi-layered approach, which I understand and agree and accept. And hello to Ms. Carta, by the way. And that being said, if I was to say, all right, what's the one thing that we could do if we were prepared to do it that would make this real? Is there a one thing?
Let me make sure I understand the question. You mean with our community partners making parity real?
Anything at all? Well, I'll tell you where I'm going with my second question. That may help you answer the first question.
Yeah, that would be good.
What I'm trying to do is say, you know, much of what we've heard, I think, around the parity issue is people have rights. It's tough to enforce those rights. The way you can help people enforce the rights is by helping them understand the process and knowing that they have the rights in the first place and making them more effective advocates for themselves. That's a huge lift. And you've been candid about that. So, okay, we all know that. So I'm saying yes, but what's the one thing we could do that would make this real? And so my second question is going to be to County Counsel's office, looking down at Mr. Press now, and Ms. Hanson's glad she now works for the COO because she's leaning out as COO. You know, is this one of those cases where, you know, there's some necessity for litigation involving non-compliant insurers who are not stepping up to meet their obligation under state or federal law? And does the county have standing to take such action if it were the will of the county, the board, to do so? So, Dr. Smith, you want to let counsel go, or you want to lean in first? Either way. I've now mushed my two questions together in the interest of full disclosure.
Let him go first. And then
I
I'll try to
thought you might. Okay.
Clean up the pieces.
Mr. Press?
Sure. So I think we've touched upon this in prior meetings, but in part, I guess I would ask who is the intended target? In other words, if you're saying, hey, someone is not giving me something that I, as a consumer or a patient, deserve and or are entitled to, we would need to know who it is that they are aiming at before we could say, here's what your remedy might look like. It might be a state regulatory remedy. For example, the Department of Managed Healthcare has all sorts of enormous enforcement powers to ensure that people get the care that is promised to them through their managed care plan, for example. So I guess I would want to know if there were some precise circumstances that we could look at to say, I think the answer here would be to go to this or that regulatory agency, or depending on the circumstance, perhaps it's something that we could get involved in.
Well, let me think out loud a little bit, which is, I know, dangerous, but since we're trying to tease out some, at least I'm trying to tease out some possibilities that, have real results. It has been my observation and experience in working with folks in my district that a big part of the challenge here is that folks who have coverage can't get the coverage that they are entitled to. So then the question is, how do you make people deliver the coverage they're supposed to? And I mean no disrespect to various state or federal regulatory agencies, but I'm sure they're overburdened and receive a lot of these complaints and are, frankly, in some cases, relatively toothless. So then the question is, what is it that will get people to do what they're supposed to do? And, we have an impact litigation team for a reason. It's not an abstract or intellectual exercise. And, if we need to identify individuals within our county who are not getting their needs met, or more legally framed, whose rights are not being honored under state or federal law, if litigation is the necessary tool, then I would be prepared to use that tool. Now, whether that's through our county council directly, as we have done so many times in other venues, we certainly did during the Trump administration when we thought the federal government was wide. We have the lead paint example going back 25 years now. I'm not going to put them on the spot, but I'm betting that our friends at NAMI would be happy to help identify a couple of real cases if you needed somebody who had standing who could be there. I'm not putting them on the spot, but we just heard from Bay Area Legal Aid, who said they do this kind of work, who could conceivably be a partner if that was deemed appropriate. But I'm asking these questions because I candidly don't think, I think public education is helpful and important. I think empowering consumers is always a good thing, but I don't think it's going to be sufficient to change attitudes in the industry. And if the largest county in Northern California has to go after some folks to make sure that they deliver what they're supposed to deliver under state and federal law, I'm ready to take that step.
Agreed. I guess just the point that I want to emphasize is, as you often point out, our healthcare system is not really much of a healthcare system for a variety of reasons. It's very difficult to navigate. We have many different programs that provide that navigation. My own experience working in a former life for some of those healthcare regulatory agencies is that sometimes the issue is one of navigation, that people just don't know how to get connected to the services that they are lawfully entitled to and that frankly are available. Then there's a regulatory gap where the services are there, they're entitled, but for some reason they're not being provided. The third step is when those first two things don't work out, then we go to the legal action step. And I agree with you. I think we have very capable attorneys in our county counsel's office who are very creative, who, when we have some circumstances that we can look at that are very specific, we can fashion some letters, maybe even some legal theories, and put together some actual actions, as we have done in many other circumstances. But that's where, if we could get some of these specific details, I think that would be really helpful.
All right, then what I'm going to do is, well, first, apparently I've been too tactful, which is not often a concern. I believe it's pretty straightforward. I believe there are insurers out there who have this obligation, who are not meeting their obligation under state and federal law, and that the only thing that will compel them to deliver the services they are required to provide under state and federal law is the threat of litigation or litigation itself. I don't doubt for a moment that navigating and articulating is a part of the problem along the way. But I think probably any of the advocates could tell you of cases where folks have been on the line, and when they said, I need the help I'm entitled to, they've been told, well, we're not really sure, or we don't think so, or gee, we need more. At some point, there needs to be a change in the behavior of the folks who are obliged to provide these services, full stop.
Mm-hmm.
So I'll ask you for a little help here in terms of how we proceed, and then I'll go to Dr. Smith for a little more help. He can be your phone a friend on this one. If you'd like, I can do this through a referral to the full board so that you get Brown Act compliant direction to take this up. I'm happy to do that. In the meantime, what I'd like to ask is that if the county counsel's office is willing and able to reach out to folks at NAMI and at Bay Area Legal Aid, who we've heard from, and other appropriate stakeholders, which gives you all the room in the world, and begin to think through what potential legal strategies might be helpful and appropriate to generate more compliance with state and federal law. Okay, good. And I think I startled some of my colleagues in a different public health matter when I said the time for tepid incrementalism is over. But if we're going to sit here in a county where we've said that that mental health is a public health crisis, then let's be real about it. Words alone will not produce a change in behavior. Dr. Smith, you've had time now to get a fuller understanding of where I might be headed on all this. Any additional thoughts?
Well, answering your first question, what's the one thing that we could do? I will fall back on Cesar Chavez's strategies for changing society, which is first you have to appeal to the people on the street, second you have to appeal to the legislature, and third you have to appeal to the courts. So I think it's really a multifactorial issue, but I would start with those three agendas. I think the regulators, as was pointed out in this conversation, are a bit at a loss in order to enforce the current laws, I think there needs to be stronger push from the legislature and stronger penalties to enforce the compliance from the providers. I think there is a need to have the public made more aware in a political sense of the issue. There's lots of reasons why people hide the fact that they or their family members have mental illness. And so until we get a more open perspective on that, it'll be hard to push the legislature and others to comply. And then you've already just discussed the legal issues, and they are difficult to comply or to push. So I don't think there's a single approach. The other confounding factor is that, for example, I was chastised by email by one of the directors of the provider that I criticized at a last meeting, making it clear that they don't believe they have a problem. So if people don't believe they have a problem, it's pretty hard to fix it. So that would be the best answer I could get to that question.
Thank you. I think the analysis is spot on. And Dr. Smith, I think I've shared this with you previously in another venue, but not with Mr. Press, perhaps, or others who are here. Part of what happens in these conversations is that people urge patience. And, again, if you're going to call something a public health crisis, then that suggests to me a certain measure of urgency is called for. And Dr. Smith, I shared with you, I think, but, the person who first fostered some understanding of these mental health parity issues, in my case, was my then colleague, Supervisor Jim Bell, 25 years ago. So, just as 50, 60, 70 years after Brown versus Board of Education, it's pretty clear there's still some work to do in that arena. I'm sitting here as someone who's been part of these conversations now for 25 years, still seeing the need to confront the issue of mental health parity and saying, all right, I think people have been patient long enough, and it's time to take it up a notch and see if we can't actually get something done. So, Mr. Press, I made a request of you rather than provide direction that might or might not be Brown Act compliant. Is that a request that you think you can respond to prior to getting a formal direction from our Board of Supervisors by way of a formal referral, which I'm looking to my office staff, Mr. Savage, to get a nod that we're headed toward?
Would it be helpful to give you a confidential off agenda on this?
Absolutely. Just know that I'm coming with a referral, but the referral will be a better one, I am sure, if we have the benefit of understanding the lay of the land. And Ms. Hanson, notwithstanding the fact that you're not in the County Council's office, I see you leaning in. Is there something that you might like to share?
No, only just that I think it will be great to see a referral on this to just have a formal opportunity for the County Council's office and specifically our health and hospital and impact teams to provide you with some information about what we see as both the opportunities and the complexity of the issue.
Got it. All right. Supervisor Lee, thanks for your patience on that one.
First of all, I want to go ahead and move per recommendation and also accepting the addendum that you've added on your comments. I want to applaud our staff for the important work that you're doing regarding the importance of highlighting the issue of parity on mental health. Our society has not viewed mental health illness as equal to physical illness. Our Healthcare insurance company certainly does not do that as well. Our military doesn't do that as well. When you get injured in the field, you get a Purple Heart medal. But if you come back with mental health issues, PTSD, you don't get any recognition for it. If anything, you get a stigma out of it. You might be demoted. You might be asked to leave the service. And so I think these type of issues are still very real in our community in so many ways. And we've talked about in different ethnic communities, the stigma of mental health is even greater. And now we also have the issue of untimely access to mental health, that people takes weeks, not days, weeks, or not over a month to schedule an appointment. That's completely unacceptable, and I applaud Supervisor Samidian for coming up with some very ingenious potential ideas through the legal means to try to get that parity to be more available by our providers. So I just want to say thank you for that, and I look forward to seeing the report and what other referral might be coming up on this. Thank you.
All right. I think we have a motion from Lee, a second from Samidian. I believe we've heard from all of our speakers, so let's call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Samidian?
Aye. Thank you very much. That takes us to item number 9, which is the possibility of a new Valley Health Center in the West Valley on the De Anza campus. I see Mr. Lorenz and Mr. Draper have attached their name to the memo. Who would like to present? I do, of course, have some questions, which will not surprise you.
Chair Samidian, I'll take the lead.
Please.
Thank you. So first of all, in the report, staff do indicate that on January 9th that the Community College District Board did approve a property access license agreement with the county. That has allowed us to move forward with a feasibility study for the potential of siting a health center on the De Anza campus. It is anticipated that report will be returned to your board around June of 2023.
Thank you. I'm going to ask that we hear this item at this committee February and April, as I think you have heard previously, but I will just sort of sunshine that. I'm going to ask the folks at Foothill De Anza if they will provide a public venue for conversation or sunshining in the every other month, meaning March and then May, just to make sure that we keep talking to one another briefly in an open and public venue, and that when we get to June, we don't suddenly discover we've got a problem. Is Mr. Draper still on the meeting?
He is present, sir.
Yeah, Mr. Draper, are you getting what you need to get this facility study done in a timely fashion? I worry that with so much back and forth, and I've said this before, so much back and forth between two organizations that are not used to working with each other, that are themselves large and challenging bureaucracies. We've got all the rules that counties have to deal with. The community college district has all of the state rules they have to deal with. It's a challenging partnership for reasons that we've discussed. No harm in acknowledging that. In fact, I'd say it's necessary to acknowledge it. So, Mr. Draper, are you getting what you need to be able to carry this out?
They're cooperating fully with us. There may be some technical drawings and sets of stuff that have to be developed through the process supervisor, but they're definitely supporting us at this point.
All right. And I have said before, but I want to say again, just for the record, and with Mr. Lorenz, with you seated at the dais, and I have said this individually, but not publicly, to folks at the Foothill De Anza board, we want to do this right, but we also don't want to turn it into a Christmas tree that is so laden with expensive ornaments that it cannot get done. So let's keep our eye on the prize here. And yeah, I know parking's always an issue, and yeah, I know we want to keep the solar options available and so on and so forth. But the goal here is to provide health care to a community that needs it. Last thing, Dr. Smith, and I shouldn't ask the question, but I will anyway. We had a fascinating discussion yesterday about health care that was sort of fun for me as a longtime member of this committee, just sit back and listen a little bit. You've been supportive of this effort, so I want to say thank you. Presumably, pending the feasibility study, you're still supportive of this effort. But what I've tried to say to people is, trust me on this, Dr. Smith wouldn't be supportive if he didn't think it made good business sense for the enterprise. Is that a fair and accurate summary, so I don't keep saying it if it's not?
Yes, that's fair and accurate, with one set of concerns, which I've also expressed to you and others. I'm a little worried about the regulations about building, state regulations about building on college campuses and what that might do to our timelines and ability to complete. But given that we probably should be able to work through that, I agree it's good business.
Thank you. And I really was referring to what I'll call the business model, and here I'll smile when I say, which I know will be more fully elaborated upon in the business plan forthcoming to the Board of Supervisors, that as you talked just yesterday about the various funding sources and reimbursement formulas that our county is subject to, that clinic operation in this location would make sense.
Yes.
Thank you. I'm always going to stop when I get the yes. Thank you. All right. I have no other comments or questions. I don't think we have any speakers on this item. Supervisor Lee, any comments or questions? Thank you. I've appreciated your
No further
interest
comments.
and support
so I
on this.
move to receive report. Thank you.
All right. Motion by Lee, second by Semidian. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Semidian.
Aye. Motion carries unanimously. Thank you. Takes us to item number 10. And I'm going to change it up a little bit here on folks. Bear with me. Flexibility is key. Mr. Margolin, I think that's you in the back row. Thank you. And what I'd like to do is ask you to present first so we don't jam you into the last 5 minutes the way we always do, particularly since I know we have a time challenge today. And what I also would like to do is ask you to make your presentation. There may or may not be questions today. But really what I wanted to do was sort of hear from you today, and thank you again for being with us, and then bring you back at the next meeting with this same item when, having had a chance to do a little more homework and research, we can follow up some more. Because as you know, this is a topic that has generated some public engagement. Okay? So, go to it. And I will get to public comment when the time comes. Thank you.
Thank you. So, is my mic on? Yes, it is. So, as we discussed at the last Health and Hospital Committee meeting, the dominant issue in Washington these days is the debt limit. And it is going to dominate all other issues. No significant policy, including health policy, will advance until the debt limit issue is resolved. There are a few relevant facts to note as this debt limit debate proceeds. First, Republicans want spending cuts or caps that have not yet been defined in exchange for their support. These are House Republicans, I should point out, in exchange for their support for lifting the limit. Speaker McCarthy has talked about limiting federal spending to 2022 levels, but that is far from a formal request. He hasn't made that formally. The Speaker and other Republicans have also said they don't want to cut Social Security and Medicare. And last night that was made especially clear during the State of the Union when the President advanced the idea that some Republicans are open to cuts in this area, and Republicans on the floor of the House protested loudly, and there was in effect a real-time negotiation that seems to have taken Social Security and Medicare off the table. The Speaker has said also that he does not want defense cuts. I'm sorry. Let me correct that statement. The Speaker has said defense cuts should be looked at, but there are a large block of Republican lawmakers who are likely to take that off the table at some point in the process. The one large spending program that Republicans are not referencing when they talk about protecting programs is the Medicaid program. It's one of the biggest programs in the federal budget, and no one on the Republican side is talking about protecting Medicaid. As I said at the last meeting, it's unlikely that Democrats will ever agree to Medicaid cuts, should there be a negotiation. The Congressional Budget Office has put forward the concept of capping Medicaid as one of the options for getting significant budget savings. But again, even though it's out there with the CBO and even though Republicans are not protecting it, it's highly unlikely that Democrats would agree to any cap on Medicaid. But there are other programs that are vulnerable, and the president last night referenced one of them when he talked about the enhanced subsidies for covered California and other exchanges that were approved, extended for 2 years in the Inflation Reduction Act. The president said last night he wants those premium subsidies extended. They're vulnerable to not being extended or being reduced in any kind of extended budget debate. And then I want to also close on the debt limit by making the point I made last time. It's worth making it a second time, which is that while many people think that the debt limit negotiations will go nowhere in terms of spending cuts because the Democrats and the president are very firm and the Republicans are divided, it is important to remember that in 2011, when this tactic was tried, Speaker Boehner, with President Obama, negotiated the Budget Control Act, which passed with 10-year spending caps and a sequestration process. The sequestration process was suspended multiple times, but there have been constraints on spending. There were constraints on spending created as a result of that. Other health issues we're tracking this year that haven't come up yet but will come up involve the DISH funding for safety net hospitals. DISH funding was cut significantly as part of the passage of the Affordable Care Act, the theory being that if you have a major expansion in health insurance, you don't need to have as much in the way of these supplemental payments to cover the cost of the uninsured. In fact, safety net hospitals have other cost pressures, other demands, other populations they must serve. So those DISH cuts have been deferred multiple times, but the latest deferral expires at the end of this year, and getting them extended again, the deferral extended again, will be a key issue this year. The other major health development worth noting is the COVID state of emergency expiring on May 11th. There are many implications to this. I want to just highlight a couple that have more or less already been addressed by the state or federal government, but it's worth us noting that. Telehealth flexibility was part of the state of emergency. Telehealth became extremely popular as a result of this option being offered. In Medicare, the Congress, in the Budget Act, decided to extend telehealth flexibility for 2 additional years, and the state of California, through a state law the governor signed, is also extending telehealth flexibility here in California. So it's not going to go away, even though the state of emergency is ending. You're well familiar, I know, members of this committee, with the end of continuous eligibility under Medicaid. It allowed the Medicaid rolls to expand substantially. There's now a redetermination process over 12 months that will soon begin. It will result in fewer people being covered by Medi-Cal. The hope is that the loss is minimized and that people who leave, for the most part, move to other kinds of insurance and are not uncovered, but some will be uncovered in all likelihood. The public health emergency also provided for an enhanced federal match, 6.2% additional match. It provided billions of dollars of additional money for California and other states with large Medicaid programs. The budget, again, passed in December, anticipated the end of the public health emergency and allowed for a several-month phase-down of this bump in FMAP, and the Governor Newsom has built that into his budget, so that's already allowed for. New leadership in the House, worth noting. There are 2 key subcommittees that deal with health in the House: Energy and Commerce and Ways and Means. The Energy and Commerce chair is now Brett Guthrie of West Virginia. Brett Guthrie, Congressman Guthrie, is a West Point graduate, military veteran, worked for many years in his family die-cast business, no particular background in healthcare, but he will be the chair of that health subcommittee on energy and commerce. Ways and Means subcommittee chair is Congressman Vern Buchanan of Florida. He's the former head of the Florida Chamber of Commerce. He spent his life building an auto dealership empire in Florida. Again, not deep background in health. The Energy and Commerce Subcommittee, which deals with Medicaid, our key concern, Anna Eshoo will continue, our local congresswoman, will continue to be the ranking member. The subcommittee itself has 30 members. It includes a total of 4 Californians. The other 3 are Congressman Ruiz, Congressman Cardenas, and Congresswoman Berrigan. So last comment about federal developments, potential for bipartisan cooperation. Behavioral health is an area that Democrats and Republicans tend to have some level of agreement on. But with this deficit reduction environment and deficit reduction discussion, it's going to be hard to get major new investment in behavioral health. Not impossible, but hard. One area where there is seemingly some potential for bipartisan cooperation is lowering the price of prescription drugs. But Democrats and Republicans have distinctly different approaches. The president last night talked about the monthly cap on insulin.
I have to tease you, I'm sorry.
Please do.
You've been telling us that for years, Mr. Moore, that there's some potential for bipartisan cooperation on prescription drugs.
That is correct. I have been saying that for years.
All right.
And I will continue to say that for at least the next several months. I may at some point give up on it. But
Thank you.
He's a positive guy.
I try to be positive. I deliver a lot of bad news. I try to put a positive ribbon around it as best I can. That's my objective. So $35 cap on insulin, Medicare negotiating drug prices. The Republicans obviously oppose these approaches. The area where there's some potential, I'm saying this at great risk, but I will say it, for bipartisan agreement is pharmaceutical benefit managers. Republicans are focusing on these PBMs as having excessive costs, and rather than saving money in the system, maybe adding costs. And there are Democrats who share that perspective and that interest. So PBMs may be the basis for, maybe I shouldn't call it bipartisan, I'll just call it agreement, and we'll leave aside the issue of which party the agreement comes from. So that's my federal report. Happy to stop here or go into the Medicare Advantage ACO portion if you'd like.
It pains me to say it, but I think we really don't have the time for the Medicare Advantage presentation today. We have the written materials.
Yes.
What I would suggest is that now that we have them and have some time between now and our meeting on March 22nd, excuse me, that we ask you to lead with that at our March 22nd meeting.
Be happy to.
And we will have you present again at the beginning of item whatever
Happy to. Thank you.
when the time comes. Thank you.
Thank you.
All right. Thank you. And that takes care of item 10H. Let me go back in order then. 10A, verbal report from the director.
Yes, and very briefly, given the time constraints here, I did want to highlight, this is February, Black History Month. In our report, we give an extensive update in terms of our efforts to advance health equity, which is a big initiative, not only for our county, but obviously for our health system. We do have Leilani Jones, our new chief and first ever on equity here in the audience, and she has been leading our efforts, not only to having healing circles, but also initiatives, including the recognition in an event during last month for each of the 3 aspects of equity that we're looking at. One of them on quality, which we recognize the Black Infant Health Program, and Dr. Cody very graciously presented that award. The workforce development, we recognize, obviously, the Behavioral Health Services Department for advancing those initiatives through the cultural competency as well as other efforts. And in terms of the social determinants of health, we recognize particularly the medical legal partnership for children that we have at VMC and what we call their new initiative, PD Power, which is Pediatricians Organizing Against Racism. And those are led by Dr. Botkin and Dr. Pooley, who were duly recognized by Paul Lorenz as well as Dr. Nguyen. The other highlight that I wanted to bring to your attention is the severe duress that many of our hospitals are going through. Dr. Smith has kept the full board informed around this by mentioning not only Hawkins in our neighboring county, but as you know, the recent complete and total closure of Madera Hospital, Community Hospital, and north of Fresno, which leaves a vast section of the valley without a community hospital. This has led to a major initiative by the California Hospital Association that you're going to be hearing a lot more as part of the state budget deliberations. They're seeking an urgent and immediate $1.5 billion funding from the state of California. And I think Carmela Coyle, who's the president and CEO, she used a very good analogy to describe the current condition, which is we had COVID hitting hospitals. It was almost a deluge in terms of a hurricane. Even though the water has receded and maybe some of the mud has left, hospitals are under a lot of duress right now, as you could imagine. And that means not only our staff, but also some of the finances, particularly in the private sector. So you're going to be hearing a lot more related to advocacy efforts around that, and I just wanted to bring that to your attention. That concludes my brief report, unless there's any questions.
No, thank you very much, Renee. I do have one question from an article that I read on the LA Times earlier this week about how Mexican pharmacies are now selling counterfeit prescription pills laced with stronger and deadlier drugs that's passing off as legitimate pharmaceuticals. And being available in Mexico, I imagine a lot of that would also be going across the border. So I'm trying to see if we have any data or any information on this, and not asking you to give me an answer today necessarily, but something that could come back to us in the future to see if this is something that we need to be aware of and how we could prevent that happening to our local communities.
Would it be helpful if we just asked for an off-agenda report on that
That would be
subject?
great.
Will do.
Thank you very much. That takes us to item 10B, which is a report from the Public Health Officer. We spent a lot of time with the Public Health Officer. Don't want to give you short shrift if there are other topics.
Very, very brief update. I wanted to let the board know that the Public Health Department is refreshing our strategic plan. That's work that's begun under the leadership of Rhonda McClinton Brown. We're directing significant effort to building out the science branch so that we have sound, evidence-based public health programs and policies. And finally, just operational, I'm sure you know that the Public Health Department has a number of large CDC grants, so we're spending quite a bit of time ensuring that we're spending down those grants and maximizing them for the benefit of county residents. And that's all I have to share. Thanks.
Thank you very much. And that would take us to 10C, the report from the Chief Executive Officer at Santa Clara Valley Healthcare. And again, mindful of time, as I had indicated earlier, if we could get Ms. Lawrence just a status report really on the CMS matters, and we'll take the matter up as an agendized item at our next meeting in March.
Thank you, Chair Simitian, Supervisor Lee. So as you well know, on January 25th, the health system received a letter from CMS. That letter noted that the system is not in substantial compliance with the conditions of participation with Medicare. What that means is that we have 90 days from the 25th of January, which is April 25th, to come into substantial compliance with the conditions of participation. This was a result of a survey that occurred back in September of 22. It was a 2-week survey in which the surveyors went through Santa Clara Valley Medical Center's system relative to our compliance to those conditions. There are 23 conditions of participation. They noted that given self-reported events over the past couple of years, that we needed to improve our processes around patient rights, our quality improvement program, as well as in nursing services. Additionally, it was noted around the physical environment, and I think it's important for me to convey to you sort of the index cases that resulted in these findings. One was a case back in 2021 where we had an ED elopement. That ED elopement resulted in a serious injury to that patient. Then subsequently in August of 2022, we did have a patient, as you well know, it was publicly reported, that jumped out of a fourth floor window on our medical unit at the hospital. And then in September, we had a situation where our emergency generators had failed. So all of these incidents are serious, which require us to have a plan of correction that is obviously was due within 10 days of the letter. That plan of correction has been submitted, and we fully expect that within the next couple weeks or thereabouts, a review from CMS around our compliance to our plan of correction. I will say that it's really important to understand in healthcare, there's very little margin for error. We're talking about patients' lives, their safety, and their well-being. And as such, it is not uncommon in healthcare settings to make sure that we are constantly looking for opportunities for improvement. That is the only way that you can remove any margin for error or mistake within a healthcare setting. That is a constant process that we undergo. This situation is very public, and rightfully so, because of the serious nature of what occurred. So it's not about just individual action, but it's really important to understand it's about system improvements to prevent instances from happening again. And so we are taking this very seriously to make sure that we have in place processes and policies in practice that in fact will allow us to ensure the public and our patients that they are under the best care possible in terms of both quality and safety. And we take that very seriously, and our staff take that very seriously. It is about transparency, and we as a system want to develop and foster a culture of safety. And that requires us to feel comfortable reporting cases like this, discussing cases like this, and making sure people know what we are doing to protect our patients. So as troubling as it is for any health system, again, I want to reiterate that this is something that not only are we taking seriously, but we know in the end we will be better for it, and your system will again be recognized as it should as a quality healthcare system. With that being said, I'm happy to answer any specific questions about this notice.
Supervisor Lee, I see your light is on.
Yeah, thank you. I know we have not much time today, but I just want to say, first of all, thank you, Paul, for the very detailed POC that you've prepared that was submitted. And certainly, we're very concerned about these issues. Some seems to be less difficult to fix, like, giving the patient the wrong language to fill out a form. I mean, those are easy ones to do to make sure that you get the right language. But certainly, there are some much more difficult ones. Some seems like might need some resources, and I think I asked about those questions yesterday regarding the generators, for example, how we can have not just double, but maybe triple. I always call it that my staff knows my belts and suspenders. In this case, maybe belts and suspenders and buttons. You just have multiple triple layers of because we just cannot possibly lose power for our hospital. That's absolutely a no-go for us. So I'm in some ways glad that it happened. It tripped. It only for a few hours because I think it allowed us to identify those issues so that we're actually getting them fixed, right? Because if you don't know that fail-safe is not there, then when something really bad happens, then really bad things would happen. So in some ways, I would say I'm glad that it happened, and I just want to say that please keep us updated on these changes. I see you also have hired a chief quality officer since then, and I think these are all absolutely important steps to move forward. And I want to make sure that we do hear these improvements coming back to us on an ongoing basis, so we will monitor this closely. Thank you.
Thank you. And Mr. Lorenz, I will just say publicly what I have said to you offline, which is that I think the CMS has identified issues that are serious and that they require a serious response from the hospital and then a commitment to follow up and follow through. I think, the risk of stating the obvious, this is not a time for box checking. This is a time for real reflection about, all right, what's it going to take? We indicated we'd set aside this brief period of time just for a status report, essentially on where things were with the regulatory process, but we'll take up a full report as a separate agendized item on March the 22nd. My recollection, and I may be off, is that were there 9 areas identified, something like that?
There were 5 areas.
Five areas. I think I had them broken down into maybe some subcategories, but we'll walk through them all with you in March, and I just want to give both you and the public a heads up on that. Okay?
Yes, sir.
All right. Thank you very much. That takes us to item 10D, and Mr. Santiago, I understand from you that Mr. Rao is not available today.
Correct.
All right, and we did take up a number of issues earlier today on both mental health parity and the progress on trust in the West Valley, so we'll look forward to talking with her next time. Item 10E would be the verbal report from the CEO of Valley Health Plan, if any.
Thank you, Chair Simidian. You have our report, and we don't have anything else to add, but I'm happy to answer any questions you may have.
I see no questions on this item, so I think we'll say thank you. And then that would take us to item 10F, the report from Emergency Medical Services, where we also had some conversation earlier today. Is there anything else from EMS today? Nope.
No, not at all.
And then that takes us to custody health. Dr. Day? Dr. Day, your mic's not on yet.
Apologies. Good afternoon. You have my report, and it's pretty consistent with our monthly reports on risk mitigation for COVID-19 and communicable disease. And so if you have any questions, I'll let the report stand.
I think the only thing I would do is say at this point, you may or may not have noted yesterday that we had a referral on our agenda regarding the Nunez case from a few years back, which of course was prior to your tenure here at the county. But it's going to raise some issues that are of direct import in terms of your current responsibilities, and just wanted to sort of underscore that for you so that when the report comes back, that you're ready to weigh in. Okay? Thank you. And I believe that covers all of the items except for public comment on item number 10. Madam Clerk, is that correct?
Correct. I have no request to speak.
All right. I do have one card from Paul Soto. I don't know if Mr. Soto is still with us. If not, last call on public comment on item number 10. Seeing and hearing none without objection, we are adjourned. Thank you all very much. And Madam Clerk, I'll just confirm for those who are listening or within the sound of our voices here that at 12:15 we will take up the Federal Affairs Advocacy Task Force. I see a change of personnel rolling in. Thank you.